Hi everyone, my name is S.H. Kim. I have been retired from the Seoul National University Hospital and now a Professor Emeritus of Radiology and now working as the Director of K Radiology Clinic and the Research Institute of Nutcracker Syndrome, and also a Consultant Professor of Ihwa Women's University Mokdong Hospital. This K Radiology Clinic is a part of Seoul K Nephrology Clinic, and we are taking care of a lot of Nutcracker Syndrome patients. Today, I want to share my experience of ultrasound diagnosis of Nutcracker Syndrome. Nutcracker Syndrome is caused by compression of the left renal vein between the abdominal aorta and superior mesenteric artery. And the mechanism of compression is similar to a nut in the two arms of a nutcracker. This is a photograph of Dr. De Schepper, a Belgian radiologist who first used the term Nutcracker syndrome in his historical article published in 1972. We need to be clear and strict in using two different terms, Nutcracker phenomenon and Nutcracker syndrome. Nutcracker phenomenon is just a phenomenon of compression of left renal vein, and it is called Nutcracker syndrome when this phenomenon is accompanied by symptoms and signs such as hematuria, proteinuria, left flank pain, or other related symptoms. The most typical symptom of Nutcracker syndrome is gross hematuria, but microscopic hematuria or proteinuria is more common. Water in the higher level naturally tries to flow down to the lower level. Likewise, left renal vein hypertension due to Nutcracker phenomenon causes development of various collateral vessels to transfer blood from the left kidney across the midline to the right-sided inferior vena cava. These fine collateral vessels may cause various symptoms, not only left flank pain, but also back pain, shoulder pain, periumbilical, epigastric, pelvic, or even right-sided abdominal pain. Nutcracker phenomenon may be related to various orthostatic intolerance, such as orthostatic proteinuria, tachycardia, or dizziness. Traditionally, the diagnosis of Nutcracker phenomenon and Nutcracker syndrome depends on the pressure gradient more than 3 mm mercury across the aorto-mesenteric left renal vein, but it needs an invasive castration. I had special interest in Doppler ultrasound diagnosis of Nutcracker syndrome, and this is an article I published in 1996 in Radiology. Normally, there is a subtle compression and narrowing of left renal vein between the aorta and the superior mesenteric artery, and the normal flow velocity in the aorto-mesenteric left renal vein is 40 to 50 centimeters per second, which is slightly higher than that of the hilar left renal vein, 15 to 25 centimeters per second. If the peak flow velocity of the aorto-mesenteric left renal vein is more than 80 to 100 centimeters per second, which is twice of the normal velocity of 40 to 50 centimeters per second, we may make a diagnosis of Nutcracker phenomenon. If we calculate theoretical pressure gradient using this Bernoulli principle, the estimated pressure gradient is between 2.39 to 3.81, which is quite equivalent to the 3 mm mercury pressure gradient criterion measured by castration. A 66-year-old man with microscopic hematuria due to nutcracker syndrome. Color Doppler ultrasound well shows bright colored jetting from the compressed aortomesenteric left renal vein, and the peak flow velocity was 147. Then we can make a diagnosis of nutcracker syndrome without invasive catheterization. A 36-year-old man with proteinuria and fluctuating glomerular filtration rate due to severe nutcracker syndrome. Aortomesenteric left renal vein is tightly compressed between the two arteries, and the absent flow signals in the dilated hilar left renal vein indicating stagnant flow, with the peak flow velocity of 182 centimeters per second. In the severe nutcracker syndrome, like this patient, glomerular filtration rate can be very different between the morning and the evening. A 30-year-old woman with proteinuria due to nutcracker syndrome, and the ultrasound shows compression of the aortomesenteric left renal vein and the dilated hilar left renal vein with absent flow signals indicating stagnant flow. Longitudinal ultrasound in the right parasagittal plane shows dilated gonadal veins, and the transverse ultrasound of the uterus shows left-sided congestion. So this is a patient with nutcracker syndrome and pelvic congestion syndrome. Nutcracker syndrome has been known as a rare disease, and it is registered in the NIH Rare Disease Site and the Orphanage Site of the United States. But there are several articles reporting that it may not as rare as it has been known, and my personal opinion is nutcracker phenomenon is very common, and nutcracker syndrome is also quite common on the basis of my experience. I reported my experience regarding the prevalence of nutcracker phenomenon and nutcracker syndrome in 2020 Annual Congress of the Korean Society of Ultrasound in Medicine. And among the 1,223 patients examined with Doppler ultrasound in my clinic for 1 year, 372 patients, which is approximately 30%, were found to have nutcracker phenomenon. And 184 of these 372 patients, approximately 50% of those with nutcracker phenomenon, could be diagnosed as nutcracker syndrome. This is a 28-year-old woman who was found to have proteinuria for 20 years, so from the childhood, without clear diagnosis for her proteinuria. Grayscale ultrasound shows narrowing of the aortomesenteric left renal vein, and color Doppler well shows jetting of the bright colored flow from the narrowed aortomesenteric left renal vein, and peak flow velocity was 147 centimeters per second. So this is a nutcracker syndrome patient and belongs to this area of the diagram. Another nutcracker syndrome patient with intermittent left flank pain, and ultrasound images shows similar findings of the narrowing of the aortomesenteric left renal vein and bright colored high velocity flow with peak flow velocity of 220 centimeters per second. And she belongs to this area of nutcracker syndrome with left flank pain. The typical pattern of nutcracker phenomenon is the left renal vein compression between the narrow space between the abdominal aorta and the superior mesenteric artery. But there are other patterns of left renal vein compression also. One of them is this pattern in asymptomatic woman with nutcracker phenomenon. If you look at the left renal vein carefully, you may notice that the left renal vein is not compressed between the abdominal aorta and superior mesenteric artery, but is compressed posteriorly by the origin of the right renal artery. And the peak flow velocity was 114 centimeters per second. So the pattern of the left renal compression in this patient is like this schema. Another pattern of left renal vein compression is like in this asymptomatic man with nutcracker phenomenon. In this patient, the space between the aorta and superior mesenteric artery is wide, and there is no compression by the right renal artery, but the left renal vein is stretched over the aorta like this schema. And the peak flow velocity was 168 centimeters per second. So we may say that there are at least three subtypes of nutcracker phenomenon. Type 1, compression of left renal vein between the aorta and superior mesenteric artery. And type 2, compression of left renal vein posteriorly by the origin of the right renal artery. And type 3, left renal vein is stretched over the abdominal aorta. But there are also combinations of those types, and this is an example. 25-year-old man, asymptomatic man with nutcracker phenomenon. In this patient, left renal vein is compressed between the aorta and superior mesenteric artery, and also by the origin of the right renal artery. Peak flow velocity in this area between the aorta and the superior mesenteric artery was 147 centimeters per second, while the peak flow velocity of the left renal vein anterior to the origin of the right renal artery was 250. So we may say that the pattern of left renal vein compression in this patient will be the combination of this type 1 and type 2. I would like to talk about the postural variations of nutcracker phenomenon, and the evaluation of this postural variation is a unique advantage of ultrasound over other imaging like CT or MRI. A 25-year-old woman with microscopic hematuria, proteinuria, and left flank pain due to nutcracker syndrome. In supine position, typical type 1 nutcracker with flow jetting from the narrow aortomesenteric left renal vein. When the patient takes left lateral decubitus posture, superior mesenteric artery moves to the left side and the left renal vein compression is relieved, and peak flow velocity was 51.7, a normal value. And when the patient takes right lateral decubitus posture, superior mesenteric artery came back to the pre-aortic location, and the left renal vein is tightly compressed again between the aorta and superior mesenteric artery, and peak flow velocity was 220 centimeters per second. She told me that her usual sleeping posture was right lateral decubitus, and I explained about the nutcracker syndrome and about the changes of the Doppler findings with different postures, and recommended her to change her sleeping posture from right lateral decubitus to left lateral decubitus. And she came back to my clinic 1 week later with a bright smiling face and told me that her left flank pain disappeared. This case well illustrates the ability of well-performed Doppler ultrasound examination in the diagnosis and the management of the patient with nutcracker syndrome. But in this 32-year-old woman with proteinuria, the movement of the mesenteric root containing superior mesenteric artery is limited, and the degree of compression of left renal vein is also similar in supine left lateral decubitus and right lateral decubitus postures, with peak flow velocity 177, 132, and 178. On the basis of these Doppler ultrasound findings, we may suspect there are adhesions or fixation in the mesenteric root area, and we may expect changing the sleeping posture will not be very effective in this for the management in this patient. Lastly, I would like to mention about a few technical aspects we need to keep in mind when you are doing Doppler ultrasound to detect nutcracker phenomenon. First 2 points are Doppler angle and sample volume. Because the direction of the aortomesenteric left renal vein is perpendicular to the Doppler ultrasound beam in neutral position of the transducer in a patient with supine posture, we need to rotate the transducer counterclockwise to make the Doppler angle better. And we need to use a thick sample volume to include the left renal vein between the pulsating aorta and superior mesenteric artery. In this spectral Doppler ultrasound image, the sample volume is located in the left aspect of the imaging field because the transducer was rotated counterclockwise, and we may get clear Doppler spectra because the sample volume is wide enough. Another technical point to keep in mind is not to put manual compression to the left renal vein by the transducer. When we try to see the left renal vein clearly, frequently we put unintentional manual compression with the transducer. In this grayscale ultrasound, left renal vein looks compressed by the right renal artery, and peak flow velocity was 170 centimeters per second, which is much higher than 100 centimeters per second criterion. But when we try not to put manual compression to the transducer, the peak flow velocity was decreased to 95 and then 61. CT images of this patient show there is no evidence of nutcracker phenomenon. So this 170 centimeters per second is false positive data due to compression with the transducer, and this 61.6 is the true velocity in this patient. Another example showing the effect of manual compression in a 69-year-old woman with epigastric pain, probably due to nutcracker syndrome, and peak flow velocity without manual compression was 189 centimeters per second, but with some manual compression, it was 324, a big difference. So always we need to be careful not to apply manual compression with the transducer. This is the last slide and the summary. In this talk, I explained how we can use Doppler ultrasound in the diagnosis of nutcracker phenomenon and nutcracker syndrome, and also shared my experience about the various patterns of nutcracker phenomenon, postural variations, and a few technical tips. Thank you for joining this talk. And if you have any questions or comments, please email me.